pleasure to be here with you today. Thank you for joining us in this Congress. I hope it will be very practical and very useful for everyone. My name is Sergio Tamayo. I work in reproductive medicine at INSER Medellin. A little bit of history and context. So for 10 years, Edwards and Steptoe have been researching human IVF. Finally, in the late 70s, in 1978, they succeed. Louis Brown, that you see in the right picture, was born after a non-stimulated cycle and laparoscopic egg retrieval, and the world was changed. IVF is one of the most significant advances in reproductive medicine, and a huge advance has been made in the science and clinical practice of reproductive medicine since then. So today, I will show you briefly how this treatment can be done, and more specific, the ovarian stimulation process. Development came slowly. In view of the poor results, ovarian stimulation was introduced and more oocytes were obtained. And due to the offset losses that is normal or common during the IVF process, but at the end, leading to more embryos being formed and the inevitable rise in the multiple birth, and also associated with problems with the premature babies. So obviously, the neonatal units forced to decrease the number of embryo transfers. Then laparoscopic egg retrieval was replaced by transurethral egg retrieval, and then transvaginal aspiration under ultrasound control or guide. Around that same time, embryo cryopreservation, still with slow freezing, was introduced and seen as an answer to this excess embryo production. So freezing was extended also to all sites, more in Italy, where they have like policies to not inject all the eggs because they don't want to freeze embryos. And nowadays, this slow cryopreservation technique has largely changed or been replaced by vitrification. So also the ICSI starts and allow the poor quality semen to be used. But these indications were soon restored, and it has been used more widely and as a routine approach instead of traditional IVF. A steady improvement in the lab standards and competence has also helped lead to a reduction in the frequency of multiple births. Later, in vitro culture of embryos to blastocysts also helped the selection for transfer of these embryos. And time-lapse imaging has improved understanding the variety of embryological states, making it easier to select which embryo to make the transfer. Because although embryo cryopreservation has essential to support this single embryo transfer, it was realized that too many embryos were being produced and longer-term storage has becoming a problem. So gentle stimulation protocols were proposed to reduce the number of oocytes and embryos with some evidence. Some evidence says that even less doses of gonadotropins can increase the quality at the end of these embryos. Also, ovarian hyperstimulation syndrome was occurring too frequently. And there's a new kind of protocols with antagonists that can cause less frequently the ovarian hyperstimulation. So all this part of the IVF process is changing. Also, patients with low ovarian reserve um, are have like a benefit from these changes because we're going to have now different kind of protocols that can help these kind of patients having better results than in the past. So when we talk about assisted reproduction techniques or IVF, we refer to any fertility treatment in which the oocyte and sperm are used outside the human body. So starting from IVF also provide like a platform for the development of other treatments, including egg donation, surrogacy treatment, and pre-implantation genetic diagnosis. At the beginning, IVF was developed for patients with just tubal disease, but now is the treatment of choice for other causes of infertility that are like refractory to more conservative treatments like IUI or ovulation induction. IVF is the most successful infertility treatment that can be offered. And since its introduction, all of the steps that I will show you in a few moments of this IVF treatment have been improved. And this led to like a continuously rising success rates over this 20 years. And these are the 4 steps of the IVF. I'm going to show you small videos that is going to make it very easy to understand. Um, the first step is the wire simulation process and the follow-up with the ultrasound. As you see here in the video, I'm measuring the dominant follicles and the biggest diameter. They have to reach at the beginning less than 10 millimeters, and with time get into 18 to 20 millimeters. In this second video, we can see after the wire simulation, we're going to do the egg retrieval. Nowadays, we're going to do it, like I said before, transvaginal with the ultrasound guide, introducing a needle into the ovaries and aspirating the liquid from the follicles one by one. And this liquid, as you see, is going to go directly to the laboratory. And in the laboratory, they will be able to see if there is an egg in the liquid or not. And after that, they can see if it is mature or not. So the next step will be the ICSI or traditional IVF in embryo culture. So as you're gonna see in this video, the first step is to prepare the sperm sample, as you see in there. And after preparing the sperm sample, we're gonna select the better ones one by one to do the ICSI. That means put inside of each egg 1 sperm cell, like that. And after that, in the incubator, we're gonna be able to see day by day what's happening. So after 1 day, we're gonna see if the egg that we did the ICSI fertilized. And after that, the cells are going to multiply. The embryo is gonna grow until it gets into the blastocyst stage to do the last step of the IVF, that is the embryo transfer. So this is the last step. So we select or choose the best embryos. If we did genetic studies, so we're gonna choose the ones that are euploid or normal, and if not, just the better, just in the morphology. And then we put the catheter inside the uterus and put the embryos inside. Okay, so when it's indicated to do an IVF treatment? At the beginning, like I said, it was just for tubal disease, But now there's a lot of causes that can take a patient to IVF, like um, male factor problems, having a sperm count lower than 5 millions, or the morphology less than 3% of normal forms, severe endometriosis, obviously previous failure of treatment by IUI, infertility of unknown causes refractory to other treatments like ovulation induction, IUI, or even laparoscopic treatments. If the patient has been trying to get pregnant more than 5 years, it's better to go to high complexity treatment like IVF. Obviously, patients that need to perform pre-implantation genetic studies, and patients that have has like very valuable frozen semen samples, patients that has uh, oncology treatments before and they preserve the semen samples. It's better to do IVF because you're going to have more chances of getting pregnant. The objective of the treatment will be to have a lot of eggs that can fertilize and form embryos that we can use to get pregnant. Hopefully, with just one healthy baby. That's our goal today. Obviously, being very careful, avoiding like excess of this number of eggs. We don't want the patient to have an ovarian hyperstimulation syndrome, and also we can cryopreserve the excess of good quality embryos. That way we can increase the chance of getting pregnant in the future. About the requirements, before starting the treatments, it's better to be sure that the husband has sperm cells and know the quality of those sperm cells. Also, know how the ovarian reserve is in that moment, and we can do that measuring the AMH. This can help us knowing the prognosis of success of that treatment, and the patient is going to know what to expect of the treatment. And also is going to help us to calculate the doses of the wire simulation process. And at the end, the embryo has to implant, so we need to know how is the uterus before doing the embryo transfer. So I'm going to emphasize a little bit in ovarian simulation for high complexity treatments. So it's important to know the difference between these titles, like ovulation induction, ovarian high stimulation, and ovarian hyperstimulation. The last one is the one that we need for IVF. We want multiple follicles to grow because the higher number of fertilized eggs at the end will have the better chances of getting pregnant. Obviously, quality it matters, but the number is going to help us a lot. So, basic concepts like to do an ovarian simulation, we need to have in mind always anticipate to a possible response, individualize the treatment to each patient, always prevent potential complications of the treatment, and optimize reproductive potential by cryopreservation eggs or embryos. But not all the couples are the same. So not all the protocols to stimulate the ovaries can be the same. And to make it easy, we can have like normal responders. That means patients, like I put here in the slide, with normal values of AMH above 1.2 and below 2.9, and a normal number of atrial follicular count. That means more than 5 for somebody, for others it's 7. And we can have also patients that are high responders with higher levels of AMH, more than 2.9, or atrial follicular count above 15. And we can have also poor responders with low AMH and low count of atrial follicular count. This is the Poseidon criteria, a way that easily identifies the type of patient we have in front, and thus going to help us to know what type of stimulation or medication is going to be needed in the stimulation process. So we can establish like 4 groups according to age and measurement of the ovarian reserve, AMH, and alpha follicular count, and know which one of those are the lower prognosis patients. And to those, we have to add LH to the stimulation protocol. So what about the medications used in IVF? So although they were discovered at the beginning of the last century, just until the beginning of the 80s, ovulation was achieved in women with gonadotropins of animal origin with poor results because they form antibodies to that kind of medicine. After that, they use post-mortem gonadotropins, uh, but it was soon abandoned because it was causing mad-crazy-cow disease. So then the pituitary gonadotropins extracted from the urine of postmenopausal women that cause menotropins or human menopausal gonadotropins were approved at the beginning of the mid 80s. But in that year, the clomiphene was the most widely used for ovulation induction. Then day by day, the menotropins increase. The doctors increase the frequency of using the menotropins. Um, then in the late 80s appears the recombinant FSH until now that we have a lot of them, different kind of brands. And with the recombinant FSH also comes the gonadotropins release hormone agonist and antagonist. So nowadays, subcutaneous injection preparations and devices give greater comfort and autonomy to the patients. Is not one superior to the other. It's just um, because all of them have good results, but it depends of the safety, availability, cost, and other variables that has to be taken into account to select one or the other. So there are many brands. It's good to go to get like used to one of them or a few of them without saying that one is better than the other. We have like this one, the Benfola, Gonal F, uh, Pergoveris. We have also Menopure. All of them comes in different presentations. Like I said, there is like no one better than the other one. It's just the one that you have, the one that you can use. For cycles with antagonists, um, cetrotide is the one we are using now due to availability, but there is others like orgalutran that you also can use. And to make the trigger shot, we can do it with Ovidrel, 250 micrograms, which is recombinant, or we can do it with HCG, such as Choragon, or in cases with risk of hyperstimulation syndrome, we can use the gonapeptyl, that is gonadotropin release hormone agonist. We give 0.1 milligrams the day of the trigger, 35, 36 hours before the egg retrieval. So it is essential to individualize stimulation according to the characteristics of each patient: age, ovarian reserve, body mass index, response to previous cycles, to establish like a probably response prognosis to this ovarian stimulation process. Like I said before, we have normal responders, high responders, or low responders. In normal responders, we can use doses approx from 225 units every day. In high responders, we can use those lower doses like 150 units per day. And in lower responders, we can use doses something around 300 units. That's like the top doses, like our roof. So when to start the stimulation? So it depends if you have to synchronize the cycle with, let's say, a trip, vacations, or whatever. If you are going to synchronize it, the idea will be to take the contraceptive pills since the day one of the periods. So when the period arrives, and after that, stop taking it to start the stimulation between 3 and 5 days before. So we're starting the stimulation the third or five pill-free day of the cycle. If there's no need to synchronize the cycle and you can start with a spontaneous period, the idea is to start the stimulation the first 5 days of the cycle. My personal preference is to start the first 3 days. Obviously, making sure that there is no follicular dominance or cysts that do not allow us to start or have a good performance of that stimulation. And the follow-up, then will the follow-up of this stimulation process with the ultrasounds is more or less like this. So the first ultrasound after starting the ovarian stimulation it's done on the 5th or 6th day of the treatment. And depending how big the follicles are, we can repeat the ultrasounds 2 to 3 days later, and then maybe 1 or 2 days later until the follicles are measuring between 17 and 20 millimeters. These are different protocols that we can use. These are agonist protocols. Today, the one we recommend the most because it has a lower risk of hyperstimulation and because we already handle it very well is the protocol with antagonists, but still you can use one of these that is with agonists. The lung protocol, and depending on the patient and previous treatment, you can use it. If it's not, the follicles are not synchronized, one you have a very big follicle and the other one is smaller, maybe you can try this kind of protocols. The lung protocol with agonist, that it starts the agonist in the mid-luteal phase of the previous cycle, or you can use the short protocol with agonists that can block also pituitary to release LH. This protocol with antagonists can be flexible or fixed start. So the flexible one, as we can see here in this image, we start the antagonist when the largest follicle measure approx 14 millimeters or more. The fixed start protocol can be started on day 5 at night or day 6 in the morning, the antagonist medicine. Personally, I prefer to do the flexible protocol, but in patients that I cannot do the follow-up ultrasound because they don't live here, we can do the fixed one. So this will be the basic difference between these two types of protocols. As I told you, the protocol with antagonists has a lower risk of ovarian hyperstimulation syndrome. It is shorter and requires lower doses of the stimulation medicine. In addition to the rate of live birth rates, that is very similar between those two, It's very easy to do it, and nowadays is like I think is the protocol that the whole world is using the most. Um, Recently, with this publication of Lamarca in 2019, it was found that the use of progesterone is a good alternative to the gonadotropin releasing hormone analogs. This avoid the premature rise of LH, making the cycles more friendly and cheaper. So the only thing in this protocol is that it's not so good is that it has been seen that the cycles can be 1 or 2 days larger than the antagonist protocol, but also with very good oocyte numbers and also a very good rate of mature eggs. Um, these types of protocols are ideal in patients who are not going to be transferred, such as donor cycles, patients who wish to preserve eggs in a surrogacy treatment, or if they are going to carry out like a genetic studies, PGTA, and therefore they have to freeze all the embryos and perform the transfer in the future. So I will show you this type of start, the non-conventional ovarian stimulation. Um, but like I said, it's non-conventional. It's not the usual. It's used in emergency situations such as preservation of oocytes in the patient who is going to do oncological treatments. So they have to start fast the oncological treatment, so they don't have a lot of time. They don't have to wait until the period, so they have to start right away. So we can start in any time of the cycle. Um, the studies that have been published to date showed like a comparable results in terms of number of oocytes, the fertilization rate, and also the pregnancy rate. But the 2019 ESRE guides um, says that still is not for everybody, it's just for emergency situations. Um, and I have to emphasize that it's important to highlight that we cannot do the embryo transfer in this kind of treatments because the window of implantation is in a different position than normal, or it has to be. This part of the protocols, as I tell to all my patients, it's the most important. We can do the trigger with HCG alone, Ovidrel, or we can do it with gonadotropin release hormone agonist alone in the cases of high risk of hyperstimulation syndrome patients, or in whom the transfer is not planned because of other things, genetic studies, or because the center wants to do freeze all policy. Um, Also, we can do the trigger, combine the Avidrel and the gonadotropin releasing hormone. This is the dual trigger, and obviously it has to be done in patients that use antagonists, because in the lung protocol they are using before the trigger the agonist, and it's not gonna be of help during the maturation of the eggs. I bring this table to show you that this dual trigger decrease the chances of cancellation, also improve the chances of obtaining mature eggs, fertilization rates, and also improve the rates of clinical pregnancy, live birth, and apparently also decrease the abortion rate. So it's a good option, and nowadays we're doing it in every patient that we can do it. So these are some tips to have in mind before and during the ovarian stimulation process. Use the AMH and alpha follicle count to predict the response, and according to that, calculate the doses that you're going to use. So you can use the protocol you feel comfortable doing it, or better doing it. But I strongly recommend the antagonist protocol. In the long protocol, just in cases where there is like asynchrony between the follicles and it's hard to synchronize them even with pills before. Use the medicine that you have available. It doesn't matter if it's recombinant or not. Have in mind a roof or a top doses of 300 units, no more than that is not going to be helpful. More than that even can cause like a low quality embryo. So 300 is like top doses. And remember, when the trigger shot is done uh, with only the agonist, the GNAR agonist, you cannot do the embryo transfer. But if you do the dual trigger with HCG plus the gonadotropin release hormone analogous, you can do the embryo transfer. So that's very important. Uh, Today, through individualization, wire simulation is safe, effective, and friendly. But like I said, you have to individualize each patient. Keep in mind what happened in the previous cycles. There's no ideal protocol for everybody and every situation. You can change according to what happened in the previous cycle. So you have to reassess each stimulation in each cycle and see what happens. Think about the possible complications and try to avoid them using agonists. If you have like a high risk of ovarian hyperstimulation, there's another strategy to use is that use like cabergoline or other kind of treatments that avoid these kind of complications. That's all. So again, it was a pleasure to be here today. And if you have any questions, feel free to send me a text message by WhatsApp or by Instagram. I will be more than happy to answer.